Good morning. Welcome to this webinar. My topic will be of the feedback of a clinical on workflow impact of the FilmArray panel Respiratory Panel 2 implement in my adult emergency department. Just to give you an introduction about emergency department organization. As you know, the workflow of patients is sometimes different between one place to another. The situation of an emergency department can be very easy to manage when your emergency department is empty, which is never the case. Usually the real life is an emergency department completely crowded with a lot of patients coming on attending for the physician. To give you just our experience, we have every year 70,000 patients, and it's a mean of nearly 200 patients a day. When we are talking about low respiratory tract infection suspicion in the emergency department, currently emergency physicians have two medical decisions to take. The first one is to give antibiotics or not, and the second is to decide to hospitalize the patients or to manage the patients as outpatient. What are a low respiratory tract infection suspicion in emergency setting? As you know, it's the first clinical source of infection and sepsis. But the clinical pictures are very wide at entry to the emergency department. We have classically four different settings: community-acquired pneumonia, acute exacerbation of COPD, acute bronchitis, and asthma. In all those LRTI, we have also influenza-like suspicion. So LRTI represents several patients every day in all emergency departments worldwide. And if you want to make the difference between a bacterial and a viral infection, it's really a clear clinical and organizational challenge. So let's go more deeply in the organizational challenge during a flu season or a respiratory virus season. We have every winter very frequent flu or viral respiratory tract infection suspicions. Many patients every day in every emergency department. And actually we have current no prompt confirmation of the viral origin of the infection. So in this case, respiratory confinement is requested. And in our department, emergency department, we have a short stay unit where we keep patients for 1 day. So that means we need single room to confine the patient. And if we don't have the confirmation of the viral origin of the infection, this may preclude discharging the patients home because we don't have totally ruled out a bacterial infection. So the challenge is very frequent and very difficult to manage. So every year, as you know, winter is coming, and every winter we have a lot of constraints for the medical wards bed availability in our hospitals because we lack of single room and we lack of quick confirmation. So every winter, emergency departments' workflow are impacted by respiratory virus outbreaks, and we have a very clear and frequent example with our colleague pediatricians with a respiratory syncytial virus outbreak every winter. So it's exactly the same thing in adult patients. Just to give you our feedback from our hospital during the 2017 and 2018 winter season. We have a very big hospital with 1,600 beds in the center of Paris. It's one of the biggest hospitals in Paris. On the left, you have our emergency department. We have 70,000 patients a year, so nearly 200 patients per day. On the right, you have our short stay unit belonging to the emergency department. We have 9,000 hospitalizations in this short stay unit, with an average length of stay of 1 day. It's a 24-bed unit, and we have only 2 to 8 single rooms. So we changed our viral respiratory infection diagnosis process between 2017 and 2018. In 2017, we take the nasal swab of the patients, we send it to the laboratory, to the virology laboratory, and first they perform a liaison test to detect influenza A, influenza B, and RSV virus. It takes around 1 hour. In case of positive result, they stop further investigation. But in case of a negative result, they perform an extended respiratory panel, which took 24 to 48 hours. 8 different viruses were investigated. We had a time to result of this extended panel between 1 to 2 days. In 2018, we moved to another test. It was a FilmArray torch. So again, the nasal swab was sent to the virology laboratory. The test had the duration of 45 minutes, and it was a simplified diagnosis of respiratory infections with 22 respiratory pathogens tested, including 4 bacteria, and a time to result very short. I wanted to present to you now the 2 periods comparative analysis, 2 seasons. The first between November 2016 to April 2017, before FilmArray torch, and the second period between November 2017 to 2018 April with the FilmArray torch. Concerning the samples evaluated from the emergency department, it was only nasal swabs. And in the first period, we sent 249 samples, and in the second period, we sent 659 samples to the virology department. The first result is a very clear improvement in the time to result. In the first period, the time to result median was 31 hours. And in the second period, the TTR was 4 hours, 35 minutes. So a mean time to result reduction of 26 hours. And before FilmArray torch, only 6% of samples had a time to result below 4 hours. And with the FilmArray torch, we improved to 50% of samples having a TTR below 4 hours. Concerning the pathogen identified, in the first period before FilmArray, we had a positivity rate of 43%, with only 1 co-infection, and predominantly influenza A viruses. And in the second period, the positivity rate was 46% with FilmArray, and we identified 23 co-infections. I want now to just make a focus on the clinical data of those emergency department patients between the 1st of December to mid-March. So during this period, we used FilmArray Torch. We tested 462 patients with a predominance of males, and we had 8 patients with 2 distinct episodes. We split the population in 2, virus plus patients for whom we identified the virus by the FilmArray, and virus negative patients for whom we didn't identify the virus. As you can see, on the first column, the diagnosis of flu was mentioned in the emergency department report for half of the patients with definitely identified the virus. So for half of the patients, the physician didn't mention the flu diagnosis in the medical reports. Only 22% of those patients with finally a virus were isolated in a single room. For virus-negative patients, the diagnosis was evocated only in 26% of those patients, and only 10% were isolated in a single room. As you know, to help the physician to make the difference between a bacterial and a viral infection, we have also biomarkers. And we use for 2 decades Procalcitonin measurement to help ED's physician to make the differentiation. So we had a look on the combination of PCT and PCR by FilmArray in identifying viral infection. So as you can see, most of the patients had a PCT measurement, even in virus-negative patients. And the median PCT concentration was significantly lower in virus-positive patients compared to a virus-negative patient. What is interesting is that in patients with a virus identified, confirmed by the FilmArray, and with a negative PCT measurement, 18 patients received antibiotics, and it was much more higher in patients if we take the threshold of 0.2 for PCT. In this group, 46 patients received antibiotics despite a negative PCT measurement below the threshold of 0.2, and despite a virus identification by the FilmArray. So if we look at the observed workflow modifications introduced by this shortest time to result we get with the BioFire FilmArray. Concerning the in-hospital patients course, downstream the emergency department short units, for the patient for whom we had the confirmation of a virus, we maintain respiratory isolation, or we introduce isolation in case it was not before. The second consequence that we ordered a single room downstream the medical wards in infectious disease department, in internal medicine, geriatry, pneumology department. So practically, it was very important for us to have the confirmation of viral infection, to say to our colleagues in medical wards, this patient has a viral infection and we must maintain isolation. On the contrary, for virus-negative patients, we could stop isolations. We could propose the patient in double room. It was particularly useful in geriatry, where single room were not so frequent. The second workflow modification was the possibility to discharge home the patients after ED's short stay unit in case of a virus identification, and if the patient, of course, had no global clinical severity or sepsis criteria. We coupled this decision between virus-positive isolation and low PCT concentration. The third observed modification in the workflow was an increased demand for nasal swabs during this period. This was probably a surrogate of the added value of knowing very quickly if the patients had or not a viral infection. Globally, there was very high self-satisfaction for physicians having a precise etiology for the LRTI episode. It was true for the physician, but also for the patients. So if we discuss globally these results, the diagnosis efficiency of BioFire respiratory panel in this experience was 50%. We observed that the ED's clinical judgment was rather efficient because in patients with a virus confirmation, 46% of them had the diagnosis evocated in the medical chart. But the therapeutic decisions were not always logical or were not fitting with the viral diagnosis. So it's just a confirmation that we need biological tools with major added values to establish our diagnosis. If we look at the respiratory confinement, it was absolutely not rational because it was the case for only 22% of virus-positive patients and only 10% of virus-negative patients. More importantly, we observed that up to 46 antibiotic therapy were potentially avoidable. I mean, patients with a virus positive and a PCT concentration below 0.2 threshold. So for those patients, probably antibiotics were not requested and could have been avoided. Concerning the time to result, it was finally suitable for ED's patient workflow. However, there are unanswered questions, of course. We don't know yet how many effective changes in medical decision in the ED were observed concerning the knowledge of the PCR results. Of course, we are not sure of the imputability of the virus identified in the clinical pictures, and we cannot solve very easily the possibility of co-infections, bacterial and viral. Finally, we can ask the question of the suitability of a nasopharyngeal swab for lower respiratory tract infection suspicion. So, what are the conclusions and perspectives? First, the virus identification by multiplex PCR for LRTI suspicion in the ED is a real added value because of the diagnosis accuracy, because of involvement of the patient's course, and because of confinement decision. We need to have very quickly the confirmation of not of the virus infection. It is clearly a question to statuate about the point of care of this kind of device, because if we are logical, we want to have the result of the virus as close as possible to the ED's clinical decision. For the antibiotic stewardship, we think that it could be really interesting to couple the PCR identification of the virus and the host response biomarker like PCT. And this is the target of the prospective trial ProArray we will conduct in a few months. This prospective trial will randomize the patients coming to the emergency department for LRTI suspicion in a control arm with usual care of the patient and an interventional arm in which we will perform on-site FilmArray respiratory panel on the nasal swab and a PCT measurement with an algorithm to help the emergency physician to give or not antibiotic. Our criteria of judgment will be the antibiotic exposition. Thank you for your attention to this webinar.